Hello everyone. Welcome to this simple basic module on the topic heart sounds. All right. So let's begin our discussion on heart sounds. All right. Now, though I said this is a very simple topic, often in your exams you might get questions which are either directly or indirectly related to heart sounds. So it is important to have a good conceptual understanding of the topic. All right. Okay. So first of all, to begin with, what does heart sounds signify? Well, these heart sounds are actually brief auditory vibrations. Okay. What are they? They are brief auditory vibrations. They are brief auditory vibrations. Now, why are these vibrations caused? These vibrations are caused by blood flowing through the cardiac chambers. So, as the cardiac valves open and close during the cardiac cycle, the blood flowing through the cardiac chambers would produce vibrations. And these brief auditory vibrations are the heart sounds. So this is caused by blood flowing through the cardiac chambers. So the blood flowing through the cardiac chambers as the valves open and close during the cardiac cycle. So I told you these are vibrations. So more turbulent the flow is, the more vibrations will be produced. Okay, the more turbulent this flow through the cardiac chambers is, you will have more vibrations being produced. Now, when you talk of heart sounds or these auditory vibrations, you should know how these auditory vibrations are described. So, in common clinical parlance, how do you describe the heart sounds? Okay. So what are the important pointers that you should keep in mind for description of heart sounds? For description of heart sounds, what are the important points? Number one, you should make a comment regarding the intensity of the heart sounds. Okay, intensity of the heart sounds, by which I mean a heart sound can be loud or soft. Okay, so intensity, you can have a loud sound or a soft sound. So you have got to make a comment regarding the intensity. Next is regarding pitch. You have got to make a comment regarding the pitch of the heart sounds. So pitch is equivalent to the frequency. So you can have high pitch or low pitch, high pitch or low pitch. Okay. So intensity, pitch, then the location where these heart sounds are best heard. Okay. Because in the due course of discussion, you will understand that certain heart sounds are heard preferentially over certain areas of the precordium. So where is this heart sound, particular heart sound best heard is also very, very important. And finally, the point you have got to add is the timing of the heart sound in relation to the cardiac cycle. Okay. So when does it occur with respect to the cardiac cycle? So timing in relation to cardiac cycle. So these are the points that you should keep in mind for the description of heart sounds: the intensity, the pitch, the location, and the timing. So when you take the frequency wise, okay, there are certain heart sounds which are high pitched and certain heart sounds which are low pitched. So let's have a quick look on what are the high pitched heart sounds. Okay. What are the high-pitched heart sounds? Well, most of the heart sounds are actually high-pitched, including your first heart sound, second heart sound, the opening snap, okay, the opening snap, the ejection click, okay, the ejection click, the pericardial knock, okay. So all these are actually high pitched heart sounds: S1, S2, opening snap, pericardial knock, ejection click, and even your prosthetic valve sounds, that is also a high pitched one, okay. The prosthetic valve sound is also high pitched. So these are the high pitched heart sounds, okay. Now what are the low pitched heart sounds? What are the low pitched heart sounds? So whenever you think of low pitched heart sounds, three heart sounds should come to your mind. One is S3, the third heart sound, the fourth heart sound, as well as tumor plop, okay, as well as tumor plop. These are the low pitched heart sounds. So you've got to know what are the high pitched sounds, what are the low pitched sounds. Majority are the high pitched sounds. All right, this much is very clear. So with this in mind, let's move forward and let's discuss the individual heart sounds. To begin with, let's discuss the first heart sound. Okay, let's discuss the first heart sound, or the S1. All right. So first heart sound, or S1, is often referred to as the lub sound. Okay. So this lub sound occurs at the onset of ventricular systole. Okay. So this occurs at the onset of ventricular systole. That is when S1 happens. And why does this occur? This occurs from the closure of the mitral and tricuspid valve. Okay, so it results from closure of mitral and tricuspid valve. So it results from the closure of tricuspid valve and the mitral valve. But though I said this, you should keep in mind one point. See, the first heart sound does not occur by a mere clapping of the valve leaflets. It's not just any mere clapping of the valve leaflets. Actually, what happens is the closure of the mitral and tricuspid valve at that particular time, just after the closure, there is some sort of a tensing of the valve leaflets and the chordae tendineae. And that tensing is the actual reason for this heart sound, the S1 heart sound. So the actual reason is the tensing, okay, tensing of valve leaflets and chordae tendineae after valve closure. Okay, that is the actual reason why a first heart sound is produced and not just a clapping of the valve leaflets. Okay, so that point is clear. Now, the next point you should know regarding the first heart sound is the first heart sound coincides with the carotid pulse. Okay, so this actually coincides with carotid pulse. First heart sound coincides with carotid pulse. Hence, you can identify the first heart sound by timing with the carotid pulse. Okay, so you have got to time it with the carotid pulse. Always remember, for timing of the heart sounds, you only use the carotid pulse and not the peripheral pulses. And this first heart sound is best, okay, is best heard at the apex. This is best heard at apex, the first heart sound. So that point is also important. Now this first heart sound, though I told you it is S1, Remember, I told you it is the closure of the mitral and tricuspid valve. So it is very, very clear that this heart sound will be having two components. That is, it is having the M1 component. It is having the M1 component and the T1 component. So there are two components to this first heart sound. That is the M1 component and the T1 component. So the closure of the mitral valve is producing the M1 component. The closure of the tricuspid valve is producing the T1 component. Okay. So when you compare and contrast M1 and T1, this M1 sound is much louder than the T1 component. So why is it so? It's because of the higher pressures on the left side of the heart, because of which M1 is louder than T1. So there is higher pressures on the left side of the heart, because of which you will have the M1 component being louder than the T1. Now this M1 component of S1, it radiates to all the precordial areas, but is loudest at the apex. Okay, it is radiating to all the precordial areas, but it is loudest at the apex. Whereas T1, okay, is actually heard at the lower left sternal border. So M1 is actually in all precordial areas, but it is best heard at the region of the apex. Whereas T1 is actually best heard or usually only heard at the lower left sternal border. Okay, at the lower left sternal border. Okay, all right. So one thing is quite clear, very evident that in S1, the dominant component or the main component of the S1 is the M1 component, and it is actually best heard with the diaphragm. Okay, this is best heard with diaphragm of the stethoscope. Okay, that point is also clear. Now, another point you have got to note is one salient point regarding the mitral leaflet. Okay, the mitral valve leaflet, you've got to know one point. That is the mitral valve, it has got two leaflets. Okay, there is a anterior leaflet as well as a posterior leaflet. Mitral valve has got an anterior leaflet and the posterior leaflet. Now this anterior leaflet is very, very important, because this anterior leaflet is again broader and more freely mobile than the posterior leaflet. So it is almost 3 times broader, 3 times it is broader and freely mobile, which means in the M1 component, it is going to be the anterior leaflet that has a dominant say. Okay, so that is going to have maximum contribution, the anterior mitral valve leaflet. Very clear? Okay. Now, remember, whenever you discuss the heart sounds, I remember, you remember I told you to begin with that you've got to describe certain parameters of the heart sounds, and one of which is the intensity of the heart sound. So the intensity of S1, it will depend on certain factors. This is again very, very important, because only if you understand these factors, you will understand what are the conditions that can lead on to a loud S1, what are the conditions that can lead on to a soft S1. So what are the factors? Let's see them one by one. So the first factor is the position of the mitral valve leaflet when the left ventricle begins to contract. So what is the position of mitral valve leaflet? I'm saying mitral valve leaflet because M1 is the dominant component. So what is the position of the mitral valve leaflet when LV begins to contract? That is the first factor. Okay, first factor. The second factor is the leaflet mobility and the structural integrity. That is your mitral valve leaflet mobility and structural integrity. That is point number 2. Point number 3, it depends on the force of the left ventricular systolic contraction. Force of left ventricular systolic contraction. So it depends on the force. The fourth point, it depends on the PR interval. It depends on the PR interval. And finally, it would also depend on the chest wall thickness. It would also depend on the chest wall thickness. So the intensity or the loudness of S1 is dependent on these factors. Now we'll just quickly and briefly see these individual factors. So first is regarding the position of mitral valve leaflets. Okay, regarding the position of mitral valve leaflet. Okay, position of mitral valve leaflet. See, this is actually very simple. See, normally, I'm talking of normal scenario, towards the end of diastole, you will have the mitral valve which is floating in the blood in the left ventricle. Okay, so it will be floating and almost in a semi-closed position. Okay, so normal scenario, you have at the end of diastole, you will have the mitral valve which is floating, and this will be in a semi-closed position. Okay, this will be in a semi-closed position. This will be in a semi-closed position because it will further have to travel some distance. So remember, that is what actually produces, that closure is actually what produces the heart sound. So if it is widely open, that is at the onset of the systole, end of diastole means onset of systole. If it is not at a semi-closed position and if the valve is actually, say, wide open, then it will have to travel longer distance, okay, for the closure, which will produce more louder vibrations. Okay, so it definitely would depend whether at the onset of systole, are the mitral valve leaflets wide open or only partially open. So is it wide or partially open? So if it is due to some reason it is floating in such a way that it has to travel a very a short distance, it will produce a soft S1, otherwise it will produce a loud S1. I hope that point is clear. So that is regarding the position of the mitral valve leaflet. Let's move on to the next point regarding the valve leaflet mobility and the structural integrity. Okay, valve leaflet mobility and structural integrity. Again, very, very important point. See, all these are important, it all translates to multiple choice questions in your exams. So suppose in a scenario where your anterior mitral leaflet, why am I talking of anterior mitral leaflet? Because that is the dominant, component of the M1. So if the anterior mitral leaflet, due to some reason, it is fibrosed and calcific. So if you have a fibrosed and calcific anterior mitral leaflet, you tell me what is going to happen. You will have a soft S1. Okay, you will have a soft S1. So it will definitely depend on the valve leaflet mobility as well as structural integrity as well. So the third point is regarding the LV contractility. LV contractility. So which means if you have a higher force and speed of contraction, then you will have a louder S1. So if there is a higher force and speed of LV contraction, tell me what will happen? You will have a loud S1. You will have a loud S1. This is again very, very important. The next point, let's discuss regarding the importance of PR interval. PR interval. Now, this is very, very important. Very, very important. So, PR interval, okay, PR interval, it actually represents part of the diastole. Okay, so the PR interval is actually representing a part of the diastole. So, that is basics. Okay, it is a part of diastole. So, you tell me what will happen if there is a longer PR interval. A longer PR interval would mean, what does it mean? It means a longer diastolic filling time. So, it will mean a longer diastolic filling time. A longer diastolic filling time. So, longer diastolic filling time means the LV is actually getting filled. So, suppose a scenario where you have a long PR interval, a long diastolic filling time. So, the mitral valve leaflets, will be almost in a closed position. So, you'll have to travel a very, very short distance and you will have a soft S1. Okay, a long PR interval will be associated with a soft S1. Next point, it will also depend on the chest wall thickness. It will depend on the chest wall thickness. So, by which I mean, if you have an individual who is obese, okay, what do you expect? You will have a soft S1. So, obese individuals will be having a soft S1. Whereas if it is thin individuals, it will have a loud S1. So, all depends on the conduction properties as well. If you have an emphysematous chest, then again the heart sound, S1 heart sound is likely to be soft. So, these are the parameters on which the intensity of the first heart sound will depend. And let's just try to put into the clinical scenarios as well. What are the clinical scenarios producing a loud S1? Now, whatever scenarios I am jotting down now will be based on one or the other fact that I have already described. That is the factors on which the intensity of heart sounds will depend. So, what are the conditions which can cause a loud S1? One is definitely a short PR interval. Short PR interval. So, any condition with a short PR interval is likely to have a loud S1. Any condition with a tachycardia. Okay, any condition with a tachycardia. Here again, tachycardia would mean a shorter duration of the diastole. So, that also will produce a loud S1. Then, individuals with thin chest wall. Individuals with thin chest wall. Definitely a better conduction is there and you will have a loud S1. And conditions associated with increased cardiac output. Conditions associated with increased cardiac output. So, imagine of high output conditions, high output states, whether it be say thyrotoxicosis, anemia. So, all these high output states will be characterized by a loud S1. Okay, that is the conditions which are characterized by a large stroke volume. I can also say large stroke volume definitely is having a loud S1. Okay, that's clear. Now, very, very important for your exams, mitral stenosis. Okay, mitral stenosis. So, definitely in mitral stenosis, you will have the valve which is floating at a very lower position because of the stenosis and decrease flow from the atrium to the ventricular side. So longer distance to travel, definitely louder S1. And not just that, even in case of conditions like left atrial myxoma, okay, left atrial myxoma, you will have a loud S1. And atrial septal defect also you can have a loud S1, but that is because of the prominent tricuspid component. Okay, because of the prominent tricuspid component, atrial septal defect. Atrial septal defect. So these are the conditions that are characterized by loud S1. Now this is very, very important. It's very simple, but again, it will come in the exam, and please do not make a silly mistake in this topic. One point I have to tell you is that when you take mitral stenosis, okay, which is often the question that is asked, please understand that in mitral stenosis, the loudness of S1 is not related to the severity. Okay, in MS, if you take MS, loudness of S1 and severity is not having any definite relation. Because see, if you have a progressive mitral stenosis and subsequent, say, calcification of the valve, you can have a soft S1. Because naturally, as a valvular heart disease progresses, you are likely to have degenerative changes, calcification, but that will produce a soft S1. So don't think that a louder S1 will mean a more severe S1. In fact, the severity is mostly dependent on the mobility of the mitral valve. Okay, so the loudness is dependent on the mobility. So it is the mobility of the valve that will determine the loudness. And finally, let's see what are the conditions that will produce a soft S1. Similar to loud S1, what are the conditions that will produce a soft S1? The conditions producing a soft S1, a few of them we have just seen. One is obesity, okay, emphysema. Definitely you can guess why it is soft. I've already told you, maybe conditions like pericardial effusion. So in all these three conditions, the conduction properties will be affected and you will have a soft S1. Conditions associated with long PR interval. Okay, conditions associated with a long PR interval will have a short S1. If you have a low cardiac output or a poor left ventricular function, low cardiac output or a low LV systolic function, that will also produce a soft S1. Soft S1 can also occur in case of a rheumatic mitral regurgitation. Okay, mitral regurgitation, there is no effective contraction, that is happening. The forward flow is not happening. So you can have in rheumatic MR also a soft S1. Acute aortic regurgitation. Okay, acute AR, acute aortic regurgitation is also one reason for soft S1. See, regarding individual conditions, we will be discussing in the separate modules as well on the individual valvular conditions. Then regarding the myocarditis will also have a soft S1. So these are the scenarios where you will have a soft S1. Now you can have certain scenarios with variable S1. Okay, variable S1. So which you can itself guess. Variable S1 can occur in conditions like, say, atrial fibrillation, as well as complete heart block. Atrial fibrillation and complete heart block, you can have a variable S1. So loud S1, soft S1, variable S1, all are very, very important. So finally, in S1, let's also just discuss the splitting of the S1. Okay, let's discuss the splitting of S1 or the first heart sound. So splitting of the S1, remember I told you that you have the M1 component and T1 component. But in normal individuals, this gap between M1 and T1 is very, very narrow. So normally between this M1 and T1, you have a very narrow gap of around 20 to 30 milliseconds. Okay, 20 to 30 milliseconds. You have got a very narrow gap. Now, because the gap is very, very narrow, the normal first heart sound is actually heard as a single sound. So this is actually heard as a single sound normally. Now, splitting can occur in certain conditions. Say for example, if you have a right bundle branch block. So if you have a RBBB, what is it going to indicate? It is going to indicate a delayed activation of the right ventricle. So there is a delayed activation of the right ventricle means the tricuspid component is going to occur later. So because of which you will have a splitting. So RBBB is one condition where you have a splitting of the first heart sound. And the splitting is often that is appreciated with the diaphragm at the left sternal border, lower left sternal border is where the splitting is appreciated. So RBBB is the classical condition where you can have a splitting of the first heart sound. Also in conditions like Epstein anomaly, okay, you can have the splitting of first heart sound in conditions like Epstein anomaly. So these are the conditions where you can have splitting of the first heart sound. Okay, so I hope the first heart sound is very clear for you. You'll definitely get questions, especially the questions might revolve around the intensity of S1. Remember, it is a very simple question that will come, but you should not make a careless mistake, because even if it is for a tough question or a simple question, the weightage of mark remains same. So you should not make a mistake there. All right. So with that in mind, let's move to the second topic or the second subtopic, that is the second heart sound. Okay. Let's move to the second heart sound. Second heart sound. All right. So second heart sound is famously known as the dub. Okay, so lub is the first heart sound. Lub is the first heart sound. Dub is the second heart sound. The second heart sound, when you compare and contrast with S1, this is louder and higher pitched than S1. Remember, S1 is also a high pitched sound, but this second heart sound is louder and higher pitched than S1. Okay, louder and higher pitched than S1. And the second heart sound, when does it occur? It occurs at the end of ventricular systole. Okay, at the end of ventricular systole. Very, very important. Okay, or you can say the onset of the diastole, ventricular diastole. So the second heart sound is best heard over the left sternal edge. That is where this is actually best heard. And so you can have the second heart sound. But you might ask me a question, why does this second heart sound occur? Very simple. Why does this second heart sound occur? This actually occurs again because of vibrations. Remember that term? Vibrations associated with the closure of aortic and pulmonic valve. So it is associated with vibrations. Okay, vibrations associated with closure of aortic and pulmonary valve. That is what causes the second heart sound. So aortic and pulmonary components definitely means this S2 has two components, that is the A2 and P2 component. Okay. So the S2 heart sound will be having A2 and P2 component. So what is the reason why there is a separate A2 and P2 component is because, see, the right ventricular ejection, because P2 component is related to the pulmonary valve, A2 is to the aortic valve, it's very clear. See, what happens is the RV ejection usually ends after the LV ejection. Okay. So there is a delay. The RV ejection ends after the LV ejection. And this reason why, there is a early aortic valve closure and then a pulmonary valve closure because of this delayed RV ejection, that is responsible for the normal physiological splitting. So normal physiological splitting, so there is a splitting of S2, and the reason for the normal physiological splitting is a more time delay for the RV ejection. Now, one point you have got to note is regarding the splitting. This separation of the second heart sound is prominent during the time of inspiration. So, it is during the time of inspiration that you will have a prominent split, okay, into A2 and P2 components. Whereas during expiration, the split disappears. Okay, the split disappears. So this A2-P2 split disappears during the expiration, which means during expiration, the second heart sound is heard as a single sound. And if you have a splitting during expiration due to some cause, it is abnormal. Okay, it is abnormal. Okay, very, very important. So that point is also clear. Now, when you compare and contrast the A2 component and the P2 component, please understand that this A2 component is normally louder than the P2 component. So this A2 is normally louder than P2. Okay, A2 is louder than P2. So remember that the loudness of a heart sound, say for example, loudness of A2 will depend on the pressure difference across the aortic valve. So the A2 loudness is dependent on the A2 loudness is dependent on the pressure difference across the aortic valve. Is dependent on the pressure difference across the aortic valve, which is why in case of systemic hypertension, you will have a loud A2. Okay, you will have a loud A2, and for the similar reason, in pulmonary hypertension, you will have a loud P2. Okay, in pulmonary hypertension, you will have a loud P2. Okay. Now, one point I told you is the loudness or the intensity of A2. One point on which it will depend is definitely the aortic pressure. Okay, no doubt about it. But it is dependent on certain other factors also. One is the size of the aortic root. Size of the aortic root is one factor on it which it will depend. And like the previous heart sound, the mobility and the structural integrity of the aortic valve. The mobility and structural integrity of aortic valve, which is also important. Okay. It will also depend on the relative proximity of the aorta to the chest wall. Okay. So again, that is also one factor on which it will depend. If you have very obese individual, emphysematous chest, that again, the proximity, again, there would be an increased separation. So relative proximity relative proximity of aorta to chest wall, it will depend on that as well. Intensity of A2. Similarly, if you take the intensity of the P2, again on a similar line, you can say it will depend, just like you said, the other one will depend on the aortic pressure. This will definitely depend on the pulmonary artery pressure. This will definitely depend on the pulmonary artery pressure. It will depend on the size of pulmonary artery, size. It will depend on the mobility and structural integrity. So it will depend on those factors as well. Okay. All right. So A2 component, P2 component. So when you compare the intensity of A2 and P2, the intensity of P2 is actually determined by comparing its intensity to that of A2. Okay. So normally this P2 is actually a soft sound. Okay. This P2 is actually a soft sound, and usually it is heard only when in the pulmonary area. So this is a soft sound that is usually well heard only in the pulmonary area. Okay, in the pulmonary area. And remember, I told you A2 component is louder than P2. Now remember, A2 is louder than P2 in all the auscultatory areas, including the pulmonary area. So including the pulmonary area, always it is A2 louder than P2 in all areas, including the pulmonary area. So when do you say that there is a loud P2 is when you have the P2 that is louder than the A2 at the pulmonary area. Because it is the pulmonary area where, this is best heard. And normally in the pulmonary area, P2 is again softer than A2. But if for some reason in the pulmonary area, if you have P2 which is having a higher intensity than A2, you say that this is a loud P2. Okay, very, very clear. And the individual components of the second heart sound A2 and say P2, they are best heard in the second left interspace close to the sternum. Okay, so how the individual components, if you want to auscultate the individual components of the second heart sound, so it is in the second left interspace. Okay, second left interspace close to the sternal border. And this is best again appreciated when the patient is in supine. Okay, patient in supine position. All right, that is again clear. Now, remember about the splitting of S2. I told you during inspiration, RV ejection ends after LV ejection. So the LV systole, that occurs earlier than the RV systole, and because of which the aortic valve will close earlier than the pulmonic valve. So that is the reason for this splitting. Now what happens during inspiration? Okay, the split normally, widens during inspiration. That is what we learned. So what actually happens during inspiration is that when there is a inspiration, that will lower the intrathoracic pressure. So that will lower the intrathoracic pressure. And when the intrathoracic pressure is lowered, you tell me what will happen to the, the capacity of the pulmonary vessels. There will be an increased pulmonary vascular capacitance. There will be an increased pulmonary vascular capacitance. Increased pulmonary vascular capacitance, and that will prolong the RV systole duration. Okay, because the capacitance is prolonged, it will prolong the RV systole duration. It will prolong the RV systole duration. And also, this will cause, because the RV systole duration is actually prolonged, definitely what will happen, the P2 component will occur at a delayed interval or a delayed time frame. Whereas, because the pulmonary vascular capacitance increases, you tell me what will happen to the blood reaching to the left side of the heart, the LA and LV. There is a reduced blood flow. The reduced blood flow to LA and LV. So what will happen is that because of the first reason, that is a prolongation of the RV systole duration, there will be a delay in the P2 component. Whereas because there is a decreased blood flow to the LA and LV, the LV systole will happen earlier and you will have an early A2 component. So what will happen to the split? You will have a widening of the split. So the split widens. Okay, the split actually widens. So this is the normal split, during inspiration there is a exaggeration of the split. Now that is again a normalcy. Now let's learn the abnormalities of S2 splitting. Okay, abnormalities of S2 splitting. Very, very important. All right. So the first abnormality that you have got to note is regarding the wide and fixed split. Okay, wide and fixed split of S2. Again, a very simple question, but again, get your concepts right. So wide split and it is a fixed split. So wide means it is clear, there is an increased gap between A2 and P2. Now, what is the meaning of this term fixed split? Fixed means, see, normal scenarios, there will be a respiratory variation in the split, correct? During inspiration, there is a widening of the split. Expiration, it is heard as a single heart sound. So fixed split means there will be a, the wide split is there. Along with that, there is no respiratory variation. That is the point. There is no respiratory variation. There is no respiratory variation for the split. Or you can say in actual definition is there is less than 20 millisecond variation between the inspiratory and expiratory phases, because there will be a slight difference, but again the difference will be less than 20 milliseconds. Now when does this wide and fixed split of S2 occur? It occurs in conditions like atrial septal defect. Very, very important. ASD is the condition you should always think of whenever in the question you have a wide and fixed split of the S2. Also, when there is say a prolonged RV failure, okay, when there is a prolonged right ventricular failure, in that scenario also, because you have a delayed P2, you will have again a wide fixed split. Now, let's take this ASD into equation, and why is there a wide split? Let's see first of all, why is there a wide split? Why is there a wide split in S2 in atrial septal defect? So we'll see why it is wide and then we'll see why it is fixed. Why it is wide? Because see, in atrial septal defect, because of the interatrial communication, more amount of blood coming into the RV, so there will be an increased RV stroke volume and the RV ejection will be prolonged. So there is a prolonged RV ejection that is happening. There is a prolonged RV ejection that is happening. And because there is a prolonged RV ejection that is happening, you will have a delayed P2. You will have a delayed P2 because of the prolonged RV ejection, which is causing the wide split. Next question you will have to answer is, why is there a fixed split? Okay, why is there a fixed split? That's the next question you have got to answer. See, fixed split, I already told you, it means there is no respiratory variation. Now, what happens is when there is a large interatrial connection, as in case of ASD, you will have the left atria and the right atria becoming almost like a common chamber. So the differential filling that normally occurs between the RV and LV during inspiration, that no longer exists. So there is no differential filling. Okay, there is no differential filling right now. There is no differential filling. Or I can also put it like there is an equalization of pressure between the two atria throughout the respiratory cycle. So there is a pressure equalization between both atria throughout the respiratory cycle. Okay, very clear. Why is there a fixed split? There is no respiratory variation that is happening. So this is very clear. Now the next condition, okay, I hope the other one is pakka clear for you. Now what are the conditions? You will have a wide split. Okay, there is a split is wide, but with a normal respiratory variation. With a normal, that is during inspiration will be further widened. Normal respiratory variation. What are the scenarios? So this occurs when there is obviously a delay in the right ventricular emptying, as in conditions like a right bundle branch block, RBBB, where there is a delay in RV emptying. So that will cause a wide split, but remember there will be normal respiratory variation. Okay. Now next point is when there is a paradoxical split. Or you can say there is a reversed split. Paradoxical or a reversed split. In what condition will it occur? So paradoxical or reversed split occurs. See, normally it is A2 followed by P2. So paradoxical split means ulta. It is the P2 that is happening for the A2 component. So that should happen when the left ventricular emptying is delayed. So there is a delay in LV emptying. Okay, there is a delay in left ventricular emptying. So which will cause the aortic valve to close later. Okay, so there can be a delayed A2. Now, what scenarios will there be a paradoxical or a reversed split? It can occur in conditions like a left bundle branch block, a severe aortic stenosis can also produce. Similarly, a severe LVF. These are the scenarios where you will have a reversed split or a paradoxical split. So, next, coming to a scenario where you can have a single S2. This is also a potential question. Now, to have a single S2, there are two possibilities. One is, see, S2 is having A2 or P2 component, right? If there is absence of either of the two components, either A2 or P2, then there will be a single S2. Absence of either of A2 or P2 component will produce a single S2, which is right. And fusion of A2 and P2. Okay, just imagine a scenario. If there is a fusion of A2 and P2, without a respiratory splitting, that will also produce a single S2. Okay, that will produce a single S2. All right. So let's see what scenario you will have a absent, okay, A2 component. Okay, let's see what scenario you will have an absent A2 component. If you have a severe calcific aortic stenosis with an immobile aortic valve, okay, if you have a severe calcific AS with immobile aortic valve, then definitely the A2 component will be absent, because I already told you the A2 intensity will depend on what all factors. And remember, it depends on the valvular integrity as well. So if there is a severe AR, okay, if there is a severe AR due to valve destruction, okay, there is severe AR due to valve destruction, even in that scenario, you will have a absent A2 component. Similarly, you can have scenarios of absent P2 component. Okay, absent P2 component. So maybe in conditions where there is a congenital absence of pulmonary valve, congenital absence of pulmonary valve is one scenario. Then say pulmonary atresia, which again means the valve is atretic valve, or when there is a severe pulmonary stenosis. Severe pulmonary stenosis. These are conditions where you will have a absent P2 component. You can have certain scenarios where the A2 is fused with P2. So imagine a scenario of a aortic stenosis. Okay, aortic stenosis. So some cases of aortic stenosis will have a delayed A2 and subsequent fusion also. Subsequent fusion with the P2. Okay, that also can happen. So these are the salient points regarding the second heart sound. Let me just take your attention to this one picture in Harrison, which again is very simple. Okay, regarding the second heart sound. So you see the normal second heart sound, you see the inspiration, the split is there. Expiration, it is heard as a single sound. Atrial septal defect, it's very clear, you will have a wide and fixed split without any respiratory variation. Expiratory splitting with inspiratory increase is seen in case of RBBB as well as idiopathic dilatation of the pulmonary artery. Reverse splitting, we have already seen LBBB and aortic stenosis, where you have the P2 component which occurs first, which is followed by A2 component. Closed fixed splitting can occur in conditions like pulmonary hypertension as well. Okay, so these are very simple basic questions. Okay, very, very important. All right, so that ends our discussion on the second heart sound. So I think we'll move on to the next one, which is the third heart sound. Okay, let's discuss third heart sound. Let's discuss third heart sound. Okay. So third heart sound is a low pitch. Remember, S1 and S2 were high pitch sound. So this is actually a low pitched heart sound, is the third heart sound. And it is an early diastolic sound. Okay, this is a early diastolic sound. Early diastolic sound is the third heart sound, and this is best heard with the bell of the stethoscope placed at the apex. Best heard with the bell over apex. Okay, and what does this imply? The third heart sound, what does this imply? Well, this actually coincides with the rapid ventricular filling immediately after the opening of the ALV valves. Okay, coincides with rapid ventricular filling. Okay, rapid ventricular filling immediately after the opening of the AV valves. Okay, now this third heart sound can be normal. So in children, young adults, and during pregnancy, you can have a normal physiological third heart sound. Okay, so a normal physiologic S3, a physiologic S3 can be seen in scenarios like say children, young adults. Young adults means often less than 40 years. Beyond 40 years, if you see S3, definitely it is likely to be abnormal. Okay, it is likely to be abnormal. Okay, so this is physiologic S3. So beyond 40 years, definitely the presence of S3 is abnormal. Okay, is abnormal. And what are the common causes of the S3? So the common causes of S3, most importantly, you have got to keep in mind the left ventricular failure, where this S3 is often an early sign of LVF. So probably if you have a patient admitted in your ward with a left ventricular failure, you might see this very early in the disease course, but the next day you might not see this S3. So this might actually disappear. So as an early sign in LVF, you can have a S3. And also in mitral regurgitation, because of the volume overloading of ventricles, you will have again a S3. Okay, all right. And when there is a heart failure, you think of a scenario like a heart failure, you will have the S3 with a tachycardia. Okay, so in heart failure conditions, you will have a S3 with a tachycardia. So when this S3 occurs with a tachycardia, this is called the gallop rhythm. Okay, this is called gallop rhythm. Very clear. So that is called a gallop rhythm. Now S3 can occur, you can have a LVS3 as well as a RVS3. Okay, you will have a LVS3 as well as an RVS3. So LVS3 is best heard over the mitral area. The RVS3 is best heard over the tricuspid area. The LVS3 increases on expiration. Okay, this increases on expiration. Whereas RVS3, it increases on inspiration. RVS3 increases on inspiration. These 2 points also you should know regarding the third heart sound. Now let's move on to the fourth heart sound. Fourth heart sound. What are the points you should know regarding fourth heart sound? So fourth heart sound also, like S3, is a low pitch sound. So this is a soft and low pitched sound. Soft and low pitched sound is the fourth heart sound. And this fourth heart sound is best heard with the, the bell of the stethoscope at the apex. So best heard with the bell over the apex. Okay. Now this S4, okay, the fourth heart sound, it is actually a pre-systolic sound. Okay. So just like you say the S3 is a protodiastolic sound, this occurs just before S1. Okay, it occurs just before S1. And remember, if you have S4, remember S3, we know that it can be physiological or pathological, but fourth heart sound is always pathological. It is always pathological. Okay, it is always pathological. So why does this fourth heart sound occur? The reason is a forceful atrial contraction against a stiff non-compliant ventricle. That is the reason for the fourth heart sound. So what is the reason for the fourth heart sound? It is a forceful, okay, a forceful atrial contraction against a stiff non-compliant ventricle. That is the reason for the fourth heart sound. Okay. Now, what are the causes? Okay, what are the causes? Okay, of say your LVS4. Just like you said LVS3 and RVS3, you can have LVS4 and RVS4. So LVS4, it can occur in hypertension. So especially long-standing hypertension can cause a left ventricular hypertrophy. You will have a stiff non-compliant ventricle. So when the atria is contracting forcefully, you will get a fourth heart sound. You can also get in other conditions like a myocardial infarction. You can have an S4 in a myocardial infarction. Severe AS, acute mitral regurgitation, as well as certain cardiomyopathies also you can have a LVS4. Okay, you can have a LVS4. Similarly, the RVS4, similarly, if you take RVS4 can occur in conditions like, see, if you say hypertension, here I meant hypertension means systemic hypertension. So pulmonary hypertension as well as pulmonary stenosis. Pulmonary stenosis will produce RVS4. Okay, this is also very, very important. So we have discussed the basics regarding the heart sounds. Remember, it's a very simple, straightforward module. But again, directly or indirectly, this can help you, in other questions, as well. All right. Thank you.